To Grand Rounds, February 2021, and it is my distinct pleasure to introduce a colleague now, Benjamin Rodgers, who we were successful in recruiting to our faculty this past summer. He came along with his wife, Amanda Rodgers, who's in peds neurology. And I remember when I interviewed him a couple years ago, it was all about Mary. And so Mary is his beautiful, their beautiful daughter. I want to say a few things about Ben. He is from Bowling Green, Kentucky, and he had undergraduate training at Western Kentucky University in biology and psychology. He went on to graduate school here at University of Louisville and first got a master's degree in biophysics and physiology prior to matriculation from our medical school in 2014. He continued training postgraduate at Washington University in St. Louis, doing his internal medicine residency there, and eventually also his fellowship in gastroenterology. Now, all during that time, he's known for being a mentor, a teacher, receiving multiple teaching awards. He's a promoter of others, and you'll find throughout the lecture that he's very funny and very engaging, and so he's naturally a very good teacher. He has over 25 publications, over 10 abstracts, a book chapter, several grant publications, and he's working collaboratively with other researchers still at WashU on some innovative artificial intelligence type technology. So he's one of those guys that is going to be unassuming, but there's a lot that he does. So Ben, teach us something about motility at the University of Louisville.
Thanks very much, Dr. Kruger. So I have no financial disclosures. So today we're going to discuss the evaluation of common GI presentations. We're going to talk briefly about how these tests guide management, and I want to say also that I understand there's an opportunity to type in questions. If you want Jason to interrupt me, please, let him know that. I'm more than happy to be interrupted either by text or directly by voice. So please chime in anywhere you have questions. So Dr. Kruger gave most of this information. I'm going to be a little nostalgic for just a few seconds. I know this sounds a little bit silly even, but this picture at the bottom is our farm. Those we don't have both of those horses still. We still have one of those horses, but that's the exact spot I was standing when I thought to myself that maybe I could become a doctor, and I remember the moment vividly. And I was just on and Dr. Kruger alluded to this, but when I was an intern in St. Louis, I went to my division chief, and he was like, well, tell me where you'll be in 10 years. Of course, everyone gets that question. And I was actually on a phone call with him a couple of days ago, and he said that I told him right off the bat that I wanted to be in Louisville, Kentucky, doing basically what I'm doing now. And so I hope that everyone can at least appreciate that this is the dream job for me, and so it's a great privilege for me to be talking to you all this morning. Certainly for me. So thank you for the opportunity. Before I get started, too, I want to say that this talk is going to focus on very common things, very common presentations, and we're not going to deviate a whole lot from that. And the second caveat is that our team has, when I say team, I mean Doctors Abel and Stocker. We've got 2 nurse practitioners, all kinds of staff, and it's growing. And so, we've got a huge team working on motility things at the University of Louisville, and please know that. And I think that, this is going to focus on some of the adjunctive things that we do to gastroparesis, since I know the Doctors Abel and Stocker have a rapport in town with most of you, and so I know that you know them very well. So let's talk about some of the quote unquote upper GI stuff first. So this patient has chest pain. Miss Abbott's a 45-year-old woman without much past medical history who comes into your office with chest pain. It occurs often, I would say several times per week and sometimes daily, so this is a symptomatic person. She has trouble identifying, exacerbating, and alleviating factors right off the bat, at least. And she thinks that antacids might help. So she's taking Tums, and she really doesn't feel that much better. And she doesn't really have anything alarming. So she doesn't have any, no nausea, vomiting, no weight loss you see there at the end, no fevers, no B symptoms. She's not having trouble swallowing or anything like that, and she's not having blood in her stool. And so the basic workup, CBC and CMP are in the chart. She's got no new medication. So, sort of a basic initial presentation of chest pain. And the first thing to talk, to mention is that we should all always remember that the heart is a more acute organ, and so whenever possible, bring that to the front of your mind and make sure, and that's according to guidelines, obviously, and make sure that the person doesn't have any cardiac issues, and so you'll see that on the slides, but just remember that even though I'm not going to mention it throughout, that I do recognize the importance of that in literally every patient with chest pain, and in my mind at least, I try not to get too hung up. And so you initiate a PPI trial in this patient, which is fine when we talk about atypical chest pain. It's important to remember that, according to some estimates, even in ER presentations, as much as a third of chest pain will be gastrointestinal. And so once you've ruled out cardiac issues, it's really not a bad idea. And especially as we'll go through the talk, you'll see that as you talk to people more in your office, you'll see that oftentimes people lack the vocabulary to adequately describe what they're feeling. And so, thinking about GI issues in the setting of chest pain is completely reasonable and should be done, in my opinion. So you initiate a PPI trial, no response. And here we'll pause to say too, because this is also going to become a common theme. If everyone responded to a PPI, life would be peachy, but that's not the reality. The reality is that some reports suggest that as many as 40% of patients will not respond to PPI. And so those are the people that we're talking about trying to sort out. So an endoscopy has also been previously performed. You do a chart check and you see that normal, including biopsies. And a barium, and this person even had a barium esophagram before presenting to you, and they say reflux to the thoracic inlet. So what does that mean? Really not much. And so what are you going to do now? You've got somebody who you talk to them a little bit further. They've got some atypical sort of symptoms for what might be GERD, but I think that you'll often find that as you talk to these individuals, that the chest pain comes with certain factors or is related to eating or things like that. And so in the evaluation of atypical symptoms, which and even chest pain, again, I would not say is an atypical symptoms, but one of the things that you can reach for is you can try to decide exactly how often a person is having reflux. And so ambulatory reflux testing is depicted by this diagram, and you'll see, so on the right, this is all, it is as simple as it looks. We put a probe down someone's nose. Those electrodes are monitoring impedance, which is to say that it follows the simple physical rule, which is that electricity is conducted easier through liquid, and so impedance goes down in liquid, and impedance goes up when there's air. So if a person belches, impedance goes up. If they reflux, impedance goes down. And you can see that there's a pH sensor down there, and it dangles above the lower esophageal sphincter, and it gives us an idea of both the chemical makeup, is this an acidic event, or and also the physical makeup, is this liquid, is this air, is this a combination of the two? And that's pH impedance study, which again, since I'm talking about it, this is something we're doing in our lab as our staff will attest. We're doing it quite often. And so the question then becomes, well, okay, so I say that I want to find out what's going on with someone's GERD. How do I know exactly how to order the test? So for one, you can always reach out to us to ask for help. But the important thing is that if you want to get an impedance probe, if you've got somebody with proven GERD, the test should be done off of PPI and H2 receptor antagonist. And that's so that we can get a true idea of how much acidic fluid there is that's being refluxed when patients do reflux. And so the question then becomes, what's proven GERD? And according to the Lyon consensus, which is cited below, the idea is that acid exposure time is the best marker that we have right now. Now, that's not to say it's the only thing that matters, but acid exposure time over about 6% is definitive evidence. What else is definitive evidence? Barrett's esophagus, erosive esophagitis, so LA grade C or D esophagitis. The A grades and the B grades of LA grade esophagitis are a little less reliable because those are sort of interphysician dependent. And so be a little careful interpreting those. But if they've got definitive GERD, then what you can do in those patients is you can actually perform the study on therapy, and that will allow you to assess whether or not these patients have a relationship between reflux events and symptoms. And what I'm telling you indirectly is that they have this little thing that they carry around with them for the 24 hours that this thing is in their nose. And by the way, I've heard it's not that bad. So patients are a little wary, but it's not that bad. But they also carry around this little button, and they hit this button to mark when they have symptoms. And so we have this thing. We have two things actually: a symptom index and a symptom association probability, which are just mathematical ways to determine whether or not there's a true relationship between reflux and symptoms, which is very nice in patients because that gives us an idea of whether or not there's a true relationship. Okay, and this is the tracing, so we don't have to worry necessarily too much about the tracing, but you can see in the bottom of the screen, so the very bottom tracing is actually the pH, and all of the tracings above that are actually impedance tracings. And again, we don't have to worry so much, but you can see that in this fashion, there's a drop in impedance going from the bottom to the top, and then the impedance returns to the baseline from the top to the bottom. And that's classic for a reflux episode. And in fact, you see that the pH drifts briefly below 7 at the bottom. And so this is a classic acidic reflux episode. Ambulatory reflux doesn't just let us do reflux episodes, though. There are a lot of things, and this is where the other 40% comes in. If you have someone who's not responding to PPI, and they're one of that 40%, one of the other things that ambulatory reflux testing allows us to do is say, is there something else going on? And things like rumination and supragastric belch are things that I believe personally, and I'm biased, but I believe personally will gain more attention in coming years. And so this is an example of supragastric belch. And you can see that what happens here is that impedance actually rises in the first part, in the first channel, and goes down. And what that is that's air going from the upper from the oropharynx, if you will, to just above the LES, and then it goes back up. So the person brings air in through a diaphragmatic contraction and then expels it. And this is a classic supragastric belch event, and we see this on pH impedance testing. And so that's the way right now we make the diagnosis. Currently the number is 13 events per 24 hours, so we even have a cutoff for this, and that's something that we're taking a look at here at Louisville very closely. So you do ambulatory pH impedance testing, and so if the person has conclusive evidence of erosive disease, Barrett's, LA grade C or D, so that's erosive esophagitis. And so the first dichotomy is whether or not they have an elevated acid exposure or normal acid exposure on pH impedance testing. If they have elevated acid exposure, that's non-erosive reflux disease, which is to say that they didn't have any esophagitis, but they have definitive evidence. Now, that's and the other thing to remember is that a very small minority, 30% of people who are treatment naive and 10% of people who are on PPI will actually have erosive disease when you do the EGD. So it's actually less likely that you're going to find something like that, all comers taken into account, and more likely that you're going to have to find NERD through a less traditional way in order to prove GERD. So let's say they have normal acid exposure. Well, then you want to look at the symptom association probability and determine whether or not they have true events when they have symptoms. And if they do, then if there's a relationship between events and symptoms, then they have reflux hypersensitivity. If there's no relationship, then they have functional heartburn. Okay, and so this matters because this affects treatment. And as you guys know, the treatment protocols are vastly going to diverge at this point, where one person might get surgery and the other person you'll have to treat with medications and alternative therapies such as cognitive behavioral therapy or an SSRI or some other. You have to get a little bit more creative when you get to the normal acid exposure and negative SAP side of this. So let's go on. So now this is a patient. You'll see very similarly here. Mr. Babbitt is a 45-year-old man And now this individual also has chest pain, but he says it's once or twice per week. Spicy food makes it worse. So sometimes, and again, there's nothing really to help you there. So cardiac etiologies have been ruled out. PPI trials initiated, and again, no response. Endoscopy was normal, and barium also normal. So now what are you going to do with this patient? And so I would say that in this individual, what we might want to do is go back and think about it. Okay, so we've got a 45-year-old guy. What else does he have? And you talk to him some more, and he has generalized anxiety. Food is an issue. That's true. And if it's just food, you can kind of say, why don't you just stop eating the chili or whatever it is that bothers you? But you talk to him a little bit more, and he says, I think that stress might make it worse too. He's got a little bit of nausea, some joint aches, so some other symptoms that aren't GI. And so studies have shown that people who have just GI symptoms, just one issue, if they've got a single issue that really bothers them, they're going to do better with some of these alternative therapies, whereas someone who has, and in fact, if someone has more than 15 positives on their ROS, then you might want to think about something you might want to consider the GI as part of a bigger picture and try to think outside the box even more. So in this situation, what you might want to do is a Bravo, and this is just a nice diagram of what a Bravo is. We use the scope. You don't have to use the scope, but we use the scope to place this little capsule, and we actually use a pin, and we drop that thing in there, and it'll stay attached to the bottom of the esophagus just above the LES for as much as 5 days, 7 days until it gets sloughed off. And they've done studies up to 96 hours. So the pH impedance, people tolerate for the one that stays in there through the nose, people tolerate that for 24 hours, and that's about as good as we can get. For this one, they've studied for people up to 96 hours. And so you can get much more prolonged testing for people who have day-to-day variation to try to prove that even though it's infrequent, that their symptoms are quote-unquote real. This can be done at time of endoscopy, which so for many of my patients, they say, I don't think I can tolerate that thing in my nose. That's fine. We've got another test for you. And in this one, the reason that the Bravo, and in fact, a lot of the guidelines have pushed people toward Bravo, because the reality is that looking at weekly acidic events, looking at numbers of events and these sorts of things have been less reliable in predicting outcomes, surgical outcomes, than acid exposure time. So the loss from doing a Bravo isn't that high. So it's well within your rights as a clinician to say, look, I think this patient would prefer it. Let's do a longer study, a Bravo test, and see what comes out of this. Now, the thing to remember about this is that if you're gonna send someone to us for Bravo, do that off PPI. So because I can't see non-acidic events as well, you can tell pH changes and so try to draw some conclusions. But the reality is that the acid exposure time, meaning that the amount of time that pH spends below 4, is going to drive the decision making in that study. Therefore, we really need to get that acid as low as possible in that patient during that period. And so when your patient says, I really don't want to come off my PPI, I can't stand it, just say, it's just a week. Give me a week and we'll try to get an answer for you. And I have that conversation all the time, and it's just part of trying to work out atypical reflux symptoms. Okay, so that's a breeze through what we're doing at UofL for GERD. So ambulatory pH impedance monitoring, Bravo, and then if you have someone in GERD and you're having trouble, or you think that they've got something even more atypical, something like rumination, don't forget to ask, what is the quality of your symptom? And if you say, what does chest pain mean to you? What does heartburn mean to you? What does this mean to you? Then patients will tell you exactly what they mean, because patients don't know the word regurgitation. And so if it turns out that they're regurgitating after every meal, then you might want to think about rumination. pH impedance would still be a good choice for you. We can sometimes see that on high-resolution manometry. But I would encourage you to say, what does that mean to you exactly, and try to get to the heart of their symptoms. And if you do get the idea that they have some sort of reflux variant, send them to us, send them over for either the testing or any of us will be happy to see them. Third case, Miss Cabot, 45-year-old woman without past medical history, presents to your office with chest pain. So This one again is several times per week, and I'm not giving you much here. So, but not much going on, and you know how this is going to play out from the others by this point. So this one you go in, biopsies are normal, PPI doesn't help. Maybe PPI helps a little bit. You do an endoscopy, nothing serious. You don't see any, there's no malignancies down there, no big lesions, no erosions or anything like that. Now what? And let's say that you've done a pH impedance study on this person. What they might have is really prolonged bolus exposure time, meaning that liquid sits in the esophagus often, but they only have 7 events, and the events are very long, but they're infrequent. So now what are you going to do? So I would encourage you then so this is exactly what I was sort of alluding to. You got to, go back and talk to them a little bit more and say, what exactly does this mean to you? And so this Mr. Cabot tells me now that sometimes, multiple times per day, not every time he eats, but this only happens when he eats. He gets this sort of discomfort, and in the mid part of his chest, he says that it's sort of tight. And again, that he's got an extensive cardiac evaluation. It's negative. And he gets the feeling that food just won't go down. And sometimes he has to stand up. Sometimes he even raises his arms. Sometimes he tries to use liquids. Sometimes the food comes back up. And now this one bothers me now. Liquids were previously okay, but now they're an issue. And pills are also causing problems. So now this person is really having some trouble, okay? And so what you might do in this situation is the next stage for them might be a high-resolution manometry. Okay, so what you're looking at here is an actual diagram of a true high-resolution manometry. Along your x-axis, that's distance along the esophagus. I apologize. The y-axis is the distance along the esophagus. The x-axis is time. And the z-axis is depicted by the pressure topography, meaning that the pressures are different, and they're sort of, imagine them coming out at you. And for those of you who have spent any time at the Red River Gorge, you'll know that there's a sort of a topographical representation of the way mountains look on the screen. And so imagine that the red parts are the highest pressures, and the green parts are less pressure, and the blue parts are the lowest part. And so you see this peak right here in the middle. Okay, and that's esophageal peristaltic contraction. 2 smooth muscle segments, and then you've got the LES down at the bottom, and there's relaxation. And again, I don't expect you to be experts, but I wanted you to at least see what this looked like. We really use 3 major metrics in this. The integrated relaxation pressure gives us an idea of how well the lower esophageal sphincter is relaxing. Okay, the number that people want to know is 15. Anything above 15 is a little bit concerning. Then we use the distal contractile integral to tell us how well the esophagus is contracting. Is it weak? Is it too strong? Is it just right? And then the distal latency gives us an idea about how quickly contraction is initiated. I make the fellows listen to this all the time, but keep in mind that swallowing is not an excitation phenomenon. It's an inhibition phenomenon. The LES is inhibited, and you actually inhibit the esophageal neurons in order to allow progression of peristalsis. And so anytime you have a rapid swallow or failure of the lower esophageal sphincter to relax, you have a disorder of inhibition. Okay, and that's important to remember because that guides the way we sort of manage these patients. And if you're drawn to its, to the final conclusion of that, you'll realize that that's why we might inject Botox into someone's lower esophageal sphincter when it's not opening correctly, is because we want to inhibit that contraction. Okay, so we don't have to induce it to do anything. We actually have to stop it from doing what it's already doing. Okay, and some of the spastic disorders of the esophageal body themselves, also we've spent a lot of time, generally not as successfully as we wish, trying to think about how we can work with the esophageal body there too. Getting the esophageal body to contract even stronger has been a much more challenging endeavor over the past couple of decades. I wanted to show you an abnormal study. So this is achalasia type 2. Okay, notice no peristaltic contraction. You can see at the bottom the LES is not opening up. The IRP down there is 20.2, which you don't have to strain your eyes to see it. Just realize that here's a swallow. There's no swallow there. And this is classic of, this is the, I wanted to show this one because this is, for us, this is, this lets me know that this is someone that I can help, actually. This person is going to be very symptomatic, and we can help them. Let's assume that the case is just a little bit deviated now. So Mr. Dept is our fourth case. Multiple times, same situation. You've done all the same stuff. Frothy material, puckered LES on retroflexion. Now what are you going to do? And so now you've got an HRM and the IRP is 11.2. You don't see any peristalsis, but the IRP is borderline. Okay? And so now what this is, this presents a conundrum because the person sounds, they look and feel like the same patient, but you don't have any clinical, the clinical data is good, but you don't have any actual data to prove to you that this individual has a disorder of outflow obstruction. So you say to yourself, well, does this just mean that I missed a structural lesion? Is there some sort of issue down at the bottom of the LES that I didn't pick up at all? And does this person have no contraction, but they have just a ring that I missed? And so often in this situation, what you can do now, this is a technology that's completely new, but you can insert a functional lumen imaging probe or a flip probe, which is just what it looks like at the bottom left here. It's just a balloon that's blown up in the bottom of the esophagus, and it actually does not measure pressure the same way. What it does is it actually measures cross-sectional area divided by pressure. Okay, it measures pressure too, but the output is not the same. So this flip, this is the last version of flip, but this is a nice picture to show you what you're looking at. What you can see is the waist of the LES there. Okay, so you see the open esophagus, the waist of the LES, and then you see the open gastric body down below. And so what this does is it gives you an idea of how well the LES is opening. And we know that a distensibility index, which is found on the left side of the screen there, if distensibility index is low, then you've got a problem, less than 2. 2 to 3 is indeterminate. Anything over 3 is normal. But high-resolution manometry picks up about 92% or so of outflow obstructive disorders. Flip is going to pick up the rest. In studies, they've shown that of the cases that high-resolution manometry missed of outflow obstruction, and this is defined by barium now, so they use barium to adjudicate. Flip did a good job picking up all of them. And so the reason that's important is that this is inserted at time of endoscopy. So this allows you to take a look, see what's going on physically with the camera, but it also gives you an idea of what, it allows you to, at the same time as endoscopy, get a better idea of what's going on at the lower esophageal sphincter. So this is what flip looks like in real time. And at the beginning of the screen, at the left side, what you'll see is you've got some of these forward-moving contractions, and then you see these retrograde contractions. And the group at Northwestern refers to these as repetitive antegrade contractions, RACs, or repetitive retrograde contractions. Those are just RRCs. I don't know that they've got a cute name for them yet. But what you saw there, let's play it again. Repetitive antegrade contractions are normal. Retrograde contractions signify outflow obstruction. And you can see on the right the distensibility index is constantly moving. You can pause it if you need to. But on this patient, you don't really need to. You can see that it's never really crossing 2. This patient clearly has an LES that's not opening. And so you say to yourself at that point, well, if the LES isn't opening, what can I do? Well, that individual, and so this individual who has both retrograde and antegrade contractions, this person would be classified as spastic achalasia. We don't have good treatment outcomes, so you and I will not be using this right now to determine what surgery someone needs. But the person has a spastic achalasia disorder, and so right then and there you can give that patient Botox, relax the LES, and see if that will help them in the immediate term. Now we've gotten so now you've gotten an overview of a lot of what we're doing in terms of the esophagus here at UofL. Those are sort of that's part of your arsenal, if you will. The things that people are going to come to you with are going to be extremely variable. It could be, keep in mind that that person with chest pain and achalasia could easily come to you not with chest pain, but with regurgitation, and they could say, I don't have many symptoms. And in fact, when you take a look at it, we did a study with curling catheters in the bottom of the esophagus, actually, and what we found is that people who had achalasia never had trouble tolerating the catheter. They had very few perceptive symptoms of the esophagus. People who had hypersensitivity disorders had a ton of perceptive symptoms, and when you curled the catheter in their esophagus, they really knew it. They complained. The test got canceled. And so, keep in mind that people with achalasia aren't necessarily going to come to you and say, oh, I have a ton of symptoms. What they'll say is, every time I eat, I feel like there's still liquid sitting in my throat, or I'm losing weight to the tune. If they've lost a lot of weight, remember not to forget cancer, but if they've lost a reasonable amount of weight, the alarm bell should start firing, and certainly remember that it could be, again, anything: belching, cough. Cough always amazes me. Every time we look at the symptoms that someone's got from GERD, it's, cough is always up there, and that's a perennial problem for our ENT friends, of whom I have several, and they're always more than happy to talk to me about cough. But let's shift gears yet again. So Mrs. Abbott is a 45-year-old woman, past medical history, hypertension, hyperlipidemia, who presents with constipation. We see a lot of this in clinic, as you guys all know. This is a years-long issue for her, and the story that I'll often get is that this started with an event. It could be childbirth, it could be some sort of trauma in youth or something like that. But now she's having 2 bowel movements a week, which is actually not bad for some of our patients. And remember that normal bowel movements have a very wide spectrum. You can have 2 bowel movements, 3 bowel movements a day, and if you have no symptoms, to me, you're fine. You can have 2 bowel movements a week, and as long as they're okay, and they're not causing you any problems, and you have no symptoms, to me, that's also fine. It's when they become a symptomatic issue to me that I really get worked up. And you could probably ask different gastroenterologists, and they may have a different opinion, but I usually let symptoms drive the constipation issue as much as anything else. She occasionally sees blood in her stool, and this is something that I really want I think that we should all do a better job. You have to appreciate gastroenterologists, and I'm speaking to myself now as much as anyone else, but we have to do a better job at paying attention to the pelvic floor and what's gone on. Things that are very common, and if people with pelvic floor dyssynergia, half of them will have some sort of emotional, physical, or sexual trauma, and getting to the bottom of their symptoms requires us to understand the etiology, and I think it behooves us to do a better job at that when we're talking with our patients. And this lady had C-section, gave birth via C-section, so, probably no anal sphincter disruption there. She had some issues prior, which says to me, well, okay, those are definitely unrelated. And then, or, probably unrelated, I should say. And then no history of sexual trauma or physical trauma. And then she had a colonoscopy, which is nice. She had external hemorrhoids and otherwise normal, and we'll say including biopsies. And so now I think that, again, you should go and talk to these patients, and you should say, how does it feel? Does it feel that stool is getting stuck in your rectum? Do you have the sensation that you can have once a bowel movement gets going, that it will progress normally? And so you have to get a true idea of what's going on. A lot of patients will tell you that they have the sensation of incomplete evacuation, rectal fullness, or one of these things that will make you think about some sort of outlet issue. My personal opinion is that you'll find many, many more outlet issues, pelvic floor issues, than you will true colonic inertia. And taking someone's colon out for true colonic inertia really is going to require a lot of pieces of evidence, typically. But the treatment of pelvic floor dysfunction is much more straightforward, and we have some people here in town who are doing an excellent job, done physical therapy, at sorting these things out. And so I wanted to show you an anal rectal manometry. So here's an anal rectal manometry, and in this individual, this is when our nurse Amy asked the patient to squeeze. And so now what you can see is typically what you want to see is a prolonged squeeze, but you can see that the person has tried to squeeze and really has sort of sputtered along. More importantly, what Amy will do is, well, she'll say, all right, I want you to pretend you're having a bowel movement. And in this patient, this is when the patient is squeezing, trying to contract their anal sphincter, and this is also when the person is trying to simulate defecation. And the problem there is that when you're trying to simulate defecation, you should not, for one, it shouldn't look exactly like it does when you're squeezing your anal sphincter, because that's exactly the opposite of what you want to happen. What you want is, you want to push and relax your anal sphincter, and so the fact that these two look exactly the same suggests pelvic floor dyssynergia. One last caveat when interpreting, when you guys get these files back, high resolution manometry has the Chicago classification, which the first iteration of that was, I think, 2013. So we've spent 10 years working on the guidelines, establishing normals, and I feel very confident when I discuss normals, and they're accepted nationally. Anal rectal manometry, the London classification, which is very nice, and there are some very nice studies which establish normals, but there's no consensus on anal rectal manometry normals, which means that it requires a bit of comfort sort of looking at patterns. And so if you guys see numbers, if you ever see numbers and you say, these numbers seem, according to what I know, sort of okay, by all means, let me know. We can pull them up and we can review them together. I will also note, though, that Susan Dunn and her team are extremely capable at sort of getting to the heart of what each patient needs. And so there is a very collaborative relationship there. But this is what anal rectal manometry looks like. Patients are also very trepidatious about anal rectal manometry. It requires the insertion of a small catheter. You blow up a balloon. They have to defecate the balloon. But in general, I've never had, I've had, I can't think of anyone off the top of my head who came back and said that anal rectal manometry was way worse than you said it was. It's usually the opposite. Most people come back and say, it wasn't so bad. And so, this is very low risk, high yield in my book. And so I think this is another great test that we're offering here. So, in conclusion, I want you guys to email me anytime with any questions. If you can get a hold of my cell phone, a lot of you probably have my cell phone. I want you to call at any time. Please, if there's any way I can help, let me know. I'd also like to say so Doctors Abel and Kruger, and really, I guess, McLean too, I've been talking with them for years now. So this is, even though I'm, new in my time here, I've been talking back and forth with them for 3 years, and maybe Dr. Abel a little bit longer. So I really appreciate that. Dr. McLean has gone out of his way, and I can't explain how much I've bothered Dr. Stocker and actually Dr. Worth as well. Brandon and I went to med school together. He and I have returned in the same year, obviously. And his willingness to continue to respond to my text messages amazes me. Anyone else would have stopped responding, and Stocker, I guess, would be emails. So anyone else would have stopped responding to me long ago. So I appreciate that. The entire GI department has been extremely welcoming, and in fact, I would extend that to every single person that I've talked to so far. There's never been a question in my mind whether or not Amanda and I were welcome here, and so really, thank you very much. Thank you for allowing me to talk, and hopefully, I think I've given plenty of time for questions too. I was hoping we could have some dialogue here.
Thank you, Dr. Rodgers. And just mentioned, if anyone has any questions, you can unmute your microphone and ask it, or if you would like to type it in the chat area, you can do that as well. So, Dr. Kruger, you were getting ready to say something, I think.
Oh, yeah. First off, thank you very much also for that overview on, I'm going to make a joke, the ins and outs of motility through the sphincters of the GI tract.
A lot of sphincter talk.
It was a sphincter talk, and people have seen that we have emerging technologies that give us the ability to take a collection of symptoms. I think you showed very well these symptoms can be very vague sometimes or repetitive, and yet they're very different with leading to different treatments.
Yeah.
One thing also that I know you have done a great job is improving the quality of the reports. So when you get a report, we lay people don't want to see the numbers per se if we're not GI specialists. We want to see this means your patient has pelvic dyssynergy and needs to get biofeedback training, or this means your patient has achalasia and I recommend the following treatments. So I think you've not only demonstrated technologies that help you reach those conclusions, but you're giving the referring physicians the ability to take that treatment and then move on with it. I did have one question because you did not mention an age-old test that I frequently recommend, particularly in when we do consults with people that have swallowing disorders. So I want to know from you, Ben, do you think there's any value anymore about the old barium tablet cine esophagram? We used to call it the poor man's motility and the poor man's endoscopy. Do you ever use that for esophageal clearance, or does it help you leading to getting a flip versus a motility?
Yeah. So thanks for bringing that. So one of the things is that I brushed over all the barium, and so I'll answer that last. I want to say two things. For one, thank you, Dr. Kruger, because I should have highlighted this. Anything you can imagine at other facilities, as far as I know, unless there's something really there is a study that we don't do yet, but that we're getting here soon enough, and everything that you could imagine being done at the Cleveland Clinic or WashU or wherever, imagine anywhere, we do that here. And so I do want people to understand that too, and I appreciate that. That's a hugely important point. There's not a technology that we don't have. And if you look at I think everyone knows this, and so this goes without saying. I think Dr. Stocker has a better understanding of gastric stimulators than anybody and I've thought about this, probably the country and probably the world. And so there's nothing that you're missing here at UofL, okay? And I know that that's not to say and so by default, I guess I should add the caveat that Dr. Abel has been in the motility game, if you will, for I don't know. I don't want to date him. He's told me the numbers. I'll say for a long time. Since before I was staring out at those horses, Dr. Abel has been thinking about motility. I'll say it that way. And so there's that. So we do everything here. When it comes to treatment, if you guys get a report back from me and it's vague and you don't email me and I find out later, I will try to fight you. If you don't get the answer from me that you want, you let me know and I'll fix it right then. Not only will I tell you what I think, but I'll make sure that doesn't happen again. And the caveat being is that my memory's horrible, and as long as I can remember, I'll keep reminding me and we'll fix it together, I promise. Now, the flip issue versus barium. I think my opinion is that a timed upright barium is a vastly underutilized resource that has a lot of clinical value, and especially a pill. And there's, for one, nothing wrong in the world with it, and I will use it frequently to break ties. And I think that reaching for it to help you determine what's going on is completely within the purvey of a motility expert and any gastroenterologist. The thing you want to keep in mind is if you want to order a barium and you just want a barium to look for esophageal outflow obstruction, you want to do it timed, you want to do it upright, and you really want that time to be at least 5 minutes because the column, the height of the column correlates with degree of outflow obstruction, and it gives you some idea. The pill also great because it gives you an idea of the functional status. So I blew over them because they're not as fancy and new, but they should never be discounted. And there are plenty of experts, and I can think of big time names in the esophageal world, Joel Richter among them, who really have advocated fairly hard for the concept that barium was a good study and has correlated well. And in fact, they used some of the flip stuff that they were using and correlated to barium. So that's an excellent point and something that we should definitely keep in mind as we consider where things are going. The one thing about flip and HRM though is that driving management. So unfortunately, the pills, they can break a tie if you think there's true outflow obstruction or something like that. But the problem is that in the age of personalized medicine, type 1, 2, or 3 achalasia will receive different treatment. And so you're going to need some sort of idea of how well,
Right.
is their esophagus dilated? Do they have any peristalsis left? Because those are the sorts of things that direct the surgical management. And so, but an HRM and a barium are great.
Other questions for Ben?
Dr. Rodgers, I have one here from the chat area, and I'll read it verbatim. Enjoyed your talk. We need similar pediatric resources. I hope you can help us eventually build a similar program for children. The question is, what age of patient are you willing to see now? Will you see adolescents?
Willing to receive an email about any patient, and I'm willing to receive a phone call about any patient, and I'm willing to help. I guess on the record, on the record. I mean, I'm trained in adults, and so it's hard for me to put out a blanket statement. I I have been speaking with the pediatricians, and I think that I would say it in the reverse, which is that for one, our job is to take care of patients, and I completely respect that, and I'm willing to help and give advice anytime. I think that the first part of that comment is the better part, which is that I think that we should bring in some neurogastroenterologists who are focusing on kids and work to transition them in the best way to the adult world, and try to build that up. I really like the idea of building up that pediatric program. I am certainly willing to entertain seeing people younger than 18, and I think that will have to be driven on it. That's a case by case thing in my mind. And to be honest with you, I guess that's also a question for Dr. Kruger. So I'll have to get with my bosses and see. I don't understand all the implications of that, but I can tell you that the adult GI department is, I think I can speak for everybody. We're firmly committed to, if you've got somebody under 18, reach out, talk to me. We will help you sort it out, and we are willing to help with those patients. No questions asked there. The formal patient sharing process might be something we can work together, but again, email me and we can work on that too.
Would anyone else have a question here for Dr. Rodgers? Again, you can unmute your mic, or if you want, you can type it in the chat area.
Ben, I will say that that on a case, you're right, on a case by case basis, many of us have seen teenagers, even some. I mean, I've done ERCPs on 2-year-olds, unfortunately, but the reality is there are less children that require these sophisticated tests, and so GI pediatric gastroenterologists rarely do more sophisticated testing. We work with them, as Ben said, because there are several in town, and sometimes we have a peer-to-peer type conversation. Where can this child's needs best be met? And Dr. Abel has had gastric stimulators placed in 15-year-olds. So again, we work on a case-by-case basis, but it's the supply and demand thing that really drives the need for these emerging technologies. Cincinnati's not that far away, and Cincinnati Children has a bigger cadre of pediatric gastroenterologists. But that was an excellent question. So how can we reach you, Ben, when people need to order? Because your focus is going to be upper and lower, as you mentioned, since Doctors Abel and Stocker are mainly focused on the gastroparesis work. And so we tried to highlight his in ULP physicians contact information, but and obviously you see there's his email. Because we have forgotten that we have the ability to help our patients with pretty significant symptoms other than handing them a PPI. There is so much more that we can do. So I really appreciate your talk today, Ben, and I hope a lot of people got a lot out of it.
Yeah, and actually that's if I guess one last thing, if I could say it. That's another excellent point, which I think I said like 3 words on it, but it is important. Finding out that a person doesn't respond to PPI is the starting point for us. Not and I can we're doing therapies here, all sorts of therapies. We consider alginates and peppermint oil, and these things that are these things that have good data, but which are hard to become comfortable with their placement, and other medications, the use of the medications. And actually in that big New England Journal of Medicine study that Speckler had, he found that a lot of people just weren't taking whatever medication they were taking correctly. There was a huge percentage of people who just weren't taking their medication correctly, and then he couldn't randomize them, because once they started taking their medication correctly, they did great. It's diary stuff, food diary stuff, and you turn out some of these people who have quote unquote reflux end up just having celiac disease. And so patients tell you all sorts of things, and it's our job to get to the heart of what's driving them. And the things that we're offering outside of medications and PPI specifically is just vast. So that's a hugely important point.
And I'll also add that I almost feel guilty the number of referrals for EGDs, and to your point, 75% of them will be completely normal.
Mm-hmm.
And the patients get disturbed by that. Well, why did my doctor refer me for this test? Well, they wanted to rule out Barrett's. They wanted to rule out erosive esophagitis, which does happen. And then it helps, to your point, if you have obvious erosive esophagitis, that they're either not taking their PPI right, or you may need to increase it to BID dosing and head of bed elevation, et cetera. But 75% of EGDs are normal with a quote GERD symptom as the reason indication for ordering the test. And I find that a lot of primary care providers, they stop at that. They don't know what to do. And now you can help. So we have all these other things that we can offer. And so this is a great segue into the rest of what the UofL Motility is at UofL is going to expand and be able to offer our patients. Other questions for Ben? Okay, we will end, and thank you very much, and you all have a wonderful week, and we'll see you next week.
Thank you.
Thank you, Dr. Kruger. Thank you, Dr. Rodgers, and outstanding presentation.
All right, thanks, Jason. When when did you say that we'll